Hello, doctors. Today we're going to be discussing history and physical exam within the scope of pediatrics. So without much further ado, let's get started. I want to first talk about the considerations that we have to take when doing a pediatric history. First of all, in contrast to the other rotations that you may have already experienced, in pediatrics, the informant may not always be the parent, and it may not always be the patient, especially if you are dealing with a child and an infant or a toddler, anyone younger than the adolescent period. The developmental stage and age are very important when considering your pediatric history, and there are components of history taking that are dependent upon the age of your patient. For example, until the age of 5, the WHO standards for growth charts are taken and put in the patient's history. When the patient is school-aged, the social and school aspects are asked for the developmental history. When we have an adolescent patient, we use the Heads First acronym for the assessment of their behavioral and developmental stages and hallmarks. So these are important things to consider as soon as you see your patient. So there are a few vital pieces of information to remember if you are given a patient in pediatrics. The first is remember to always elicit the vaccination history. And then finally, always get the weight and the height of your patient. More importantly, the weight. You want to make sure that that is one of the first things you think of and the first things you ask when you are doing this pediatric case. To get started on the history, I have shown you here on the screen the general data. I know that you know most of this already. The major differences in the pediatric general data elicitation will be the name of the informant, the relationship to the patient, and the reliability of the informant. Now, reliability is based on the following: relationship to the patient, the number of hours that the informant spends with the patient, the educational attainment of the informant sometimes, and of course, and most importantly, the involvement in care of the informant with the patient. So for example, in a lot of the pediatric cases that you will come across, there will be a nanny or a yaya. The yaya is the one that spends most of the time with the patient while the parents are at work. So if the informant is the mother, you can and you should ask her how much time she spends with the patient, and was she there when she saw the symptoms happening, or did the yaya bring the symptoms to the mother's attention? If that is the case, then you will elicit the history from the yaya and not from the parent, because she will most likely know more about what is going on with that patient. So that is something that you want to consider. In reliability, especially if you're in OPD, you no longer quantify this as a percentage. You just say good reliability, fair reliability, poor reliability. That's pretty much it. For the chief complaint, this is where you're answering the question, why was the patient brought to the hospital? So in this case, you want to use the exact words of the informant whenever possible, and then when you go into your discussion of the case, this is when you translate the chief complaint into medical terminology within your discussion. So for example, if my patient comes in and the informant tells me, "Dok, nanilaw po siya, nag-umpisa mga ilang araw na," I would say on my form or in my presentation, the chief complaint was quote unquote, "naninilaw po siya." In my presentation, oral presentation of the case, and in my official notes, I would say the patient's chief complaint was jaundice. So that's where the difference is. When you have a chief complaint in any of the rotations, you want to make sure that you use the terminology of the patient in the history taking, and when you extract that history, you use that terminology, but when you are presenting it officially, you say what the patient said verbatim, and then you translate that into medical terminology in one sentence. So that's something that you guys want to work on. History of present illness. So before we go into all of that, I also want to point out some of the differences that the HPI has as compared to or in contrast with other rotations. First, you elicit as best possible in chronological order. This is true of almost all rotations. Actually, it's true of every rotation. But in pediatrics, it's very important because The order, the chronological order, can start prior to birth or during birth or at whatever age or how many days or how many months. So all of those days, especially in the perinatal period, matter to the history of present illness. So if the patient is a newborn or the problems are related to the prenatal or perinatal period, you have to incorporate the maternal and birth history, and I'll go over that in a later slide. So keep in mind the age of the patient during the time you're eliciting this HPI, and at the end of the HPI, this is important, at the end of your HPI, before you begin any sort of ROS and the rest of the history, you should have an initial impression, at least one initial impression, and begin to formulate your possible differentials based on the HPI of the patient. The review of systems. Most important is that you ask only symptomatology that is applicable to the age of the patient. For example, if I have an infant that presents to me with jaundice and I am doing an HPI of, for example, HEENT and asking the mom or the informant about patient's symptoms, I cannot ask her, has the patient experienced a headache? Because infants cannot quantify whether or not they have experienced a headache. So you would ask things like, has the mom noticed that the patient, has periods of rigidity? Like, for example, if we're looking for a seizure, has the mom noticed any lethargy? Has the mom noticed any sort of somnolence? Those things are what you would ask a patient who is an infant. You would not ask if the patient has fainted or if the patient has a headache, because they are not related to the age. So that goes for other things as well. If the patient cannot quantify or rate the pain, you cannot ask the question, because pain, as much as it is a accessible factor, is also very fairly subjective. And whenever you ask in the ROS about pain, the patient has to quantify that for you on a pain scale, and then you have to PQRST or old cart sit, and infants and children cannot do that. You could probably do that in an adolescent. So I am telling you, this is the most important part of the ROS, is that you ask only symptoms that the patient can actually experience. Because if they ask you, your panel will ask you, why would you ask that? Can an infant feel that? Or will a 2-year-old know if they're going through that or experiencing that? That's when you guys will trip up. So this will show your panel that you are thinking. Vice versa, they can also say to you, why didn't you ask if the patient wasn't experiencing a headache? You can say, it's because, doctor, the patient will not be able to quantify for me whether or not a headache is present or absent. They do not have an idea or a subjective explanation of pain, and therefore I cannot ask that question. So that will help your panel to see that you are thinking correctly. The review of systems is also where you explore your different differential diagnosis. So what I mean by this is that when you have your initial impression, you should automatically think of at least 2 or 3 systems that could cause that chief complaint. Those will morph into your differential diagnoses. So during the review of systems, if you know, for example, that the patient is presenting with, for example, jaundice in a child or a newborn, automatically you're thinking, okay, jaundice could be physiologic. It could be related to breastfeeding. It could also be related to hepatology or liver pathology, okay? So during your differential diagnosis, or during your review of systems, this is where you begin to ask questions related to those other systems that could possibly make up your differential diagnoses, because at the end of your presentation, these will help you rule in and rule out your diagnostics. Following that, we want to ask or look at gestational history, birth history. For gestational history, I know you guys know most of this already, but I want to bring your attention to infections and drug intake. So the infection that the mother had during the pregnancy, if ever she had one, is very important, because certain infections, like we know the torch infections, can have an effect on the child's development. Drug intake can also have an effect on the child's development, not just recreational drugs, but For example, if the mother is a bipolar patient and is taking lithium, that can have an effect on the growth and development of the fetus at the time. So you want to make sure that you note any of the drugs or supplements that she was taking during her pregnancy. Exposure to teratogens is also important, like smoking or alcohol or, again, other drugs, recreational that time. So you want to make sure that you take note of those especially. With regard to birth history, you want to note whether or not the baby was term, premature, or post-mature. The manner of delivery simply means whether or not it was a vaginal or cesarean section. Who delivered the baby is important because it speaks to the care of the child. So if, for example, the child was delivered at a tertiary care facility where the patient had a private room, they did skin to skin, they were able to vaccinate and do all of the postnatal examinations like the genetics test and things like that. That's important versus if they were born at home and they didn't have any of those tests, they weren't able to get any vaccines, etc. Birth weight is taken in all patients, I believe, less than 2 years old, and if it is applicable to the chief complaint. Following that, you also want to see their neonatal history. So that's their APGAR, whether or not they had spontaneous respirations or they had to be resuscitated, if there was any discoloration present during birth, if the patient had convulsions or hemorrhage, if there were respiratory or feeding issues, because that could be, cleft palate or cleft lip, very good. And then any congenital defects or birth injuries. I have hemorrhage listed twice, so obviously it's important. No, I'm just kidding. That's a typo, but congenital defects and birth injuries are also very important, especially with regard to cardiac pathology. For birth injuries, things like shoulder dystocia when they're coming out of the canal, that's very important as well. So please note that these last 3 things in personal history that we listed are included in the HPI always when the patient is less than 2 years old. They are included only if pertinent when the patient is greater than 2 years old. So if you have a pediatric case where your patient is less than 2 years old, these are a requirement that you ask them during your history taking. If your patient is greater than 2 years old and none of these issues come up during the chief complaint and they're not related to the chief complaint, do not ask them. Save time. For feeding history, for infants less than 2 years old, you want to take note of the feeding, complementary foods, food intake, okay, and the actual caloric intake and RENI. There's also food intolerances, which are basically like allergies, multivitamins, and iron supplements. In addition to that, you also want to make sure that you ask the type of solid food initially introduced to the patient at the time, as well as the reaction to each type of new solid food or complementary food that was given to the patient after. With type of feeding, you want to take note of breastfeeding, the type of formula if there is formula, breastfeeding to formula ratio if they are given both, and you also want to make sure and ask how much they are feeding during the day. In children to adolescents with their feeding history, this takes place for 2 to 20 years old. You don't need to ask any of the early feeding history if it's not pertinent. So you're going to focus on the appetite, the usual food intake, 5 basic food groups, and whether or not they are able to ingest this during their time, meaning like if they are getting 5 basic food groups with every meal. You want to know their actual caloric intake. You want to know what they like, what they dislike, if there are any feeding difficulties or any kind of intolerances, and also any multivitamins or iron supplements. For developmental and behavioral history, this is what I want to stress to you guys before I go into the discussion, is that it is very age-based. So the first thing you want to do after you walk into your patient's room and get the weight is you want to know how old they are, because your mind should already be thinking about what you're going to be asking. And I know that it's theoretical and you're not really walking into a patient's room, but set your mind so that you kind of have that feeling. Like pretend that you're going to be walking into the room so that you know how to gear your brain for it. Okay, so for young children aged 1 to 5 years old, we have the modified developmental checklist, which involves dental eruptions. So remember when it's normal to have teeth, when it's abnormal that you don't have teeth, things like that. Behavioral issues like incontinence, sleep disturbances, and tantrums. Remember when those appear, when they disappear, when they are normal, and when they become abnormal. You also want to know any phobias or night terrors, as well as whether or not the patient has been toilet trained. For middle school children, you ask about their developmental and behavioral history within the context of school performance, their friend groups, who they hang out with, and some of their interests and favorite subjects. So those are usually the things that you talk about the most. With regard to sexual development, you will rate them using the Tanner's maturity rating. And I trust that you guys either know that by heart or will review it as soon as you are done listening to me talk. Finally, moving into adolescence, we all know HEADS first, the acronym that we use for assessments. Special note as well, in females, you want to make sure that you take down the menstrual history, so that's MIDAS, and whether or not they do a self-breast exam and the last one that they did and what the results were, aka if they felt anything. All right, guys, so hang in there. We are nearing the end of the HPI. You want to listen and ask about past illnesses. So here we want to ask about contagious diseases that the patient had, any medical illnesses if present, and I like to use this handy acronym called HITS for past illnesses and past medical history. It stands for hospitalizations, injuries, trauma, and surgical history. So you get it all in one HIT. So remember HITS, hospitalizations, injuries, trauma, and surgical history. In the pediatric population, you also want to note whether or not there have been any allergies, development of new allergies or possible intolerances, and other atopic conditions that could lead to or be pointing toward current causes and other diseases. So those atopic conditions like atopic march could also be something that you want to take note of in case they lend themselves to other disease processes or pathologies. Finally, and important in children, the immunization history. So you want to know the types of immunizations, the ages when they were given, where they were given, if it was at a hospital or a health center, and any adverse reactions. Family history. For this, it's pretty basic for children. You want to know the parents' age, occupation, and health status, healthy, not good, not healthy. If they are deceased, you ask the age of death, the cause and nature of the symptoms, and any other family history, as well as if there's any consanguinity, which means, are they related, the parents? Siblings, you want to know the number of siblings, how old all of them are, and their states of health, as well as if they are deceased, you would like to ask the age of death and the cause if applicable. Especially if it is a sibling who has died, make sure you ask the age of death and the cause, because these could lead us to consider certain genetic diseases or certain diseases that are within inherited patterns. For socioeconomic history, you want to talk about the living conditions, so the place where they live, the nature of their dwelling place, material of the dwelling, so you want to ask, are the walls made of concrete? Is it an old house? Is it made of wood? Things like that, because those environmental factors could also give us a clue as to why patients are experiencing certain symptoms, or do their environments predispose them to certain conditions that we may not necessarily consider. In addition, you want to know how many people live in the house, so that's important. And then economic and financial circumstances, like the source of income, who works in the house, and basically how much or whether their earnings are sufficient for their lifestyle. Environmental history, with regard to pediatrics, it's easy. You just want to know if they're exposed to cigarette smoke at home, if their garbage is taken out and segregated, as well as if there's recycling. Is their sewage disposed appropriately? And you want to know water sources. So a lot of the time when you interview patients about water source, the drinking water of the parents is different from the drinking water of the children. So you want to know if this is true, and for example, if the baby or infant is on formula, you want to know what kind of water they're using to mix the formula with. You want to know if their washing water is clean, because what if the drinking water is triple distilled, but they're washing with dirty water? So that's something that you want to consider as well. And as far as hygiene, you want to also consider the presence or absence of indoor plumbing. So finally, we have reached the physical exam, and hang in there, guys. I know this is getting long, but I promise you that you are going to be fine, and it's a little overwhelming. So if you are overwhelmed, hit pause and then take a 5-minute breather and come back, okay? But I promise that you can do this, doctor. So moving forward to physical examination after you've had your little 5-minute break, I want you, before anything, to remember that your physical exam starts as soon as you see your patient. Not as soon as you speak with them, not as soon as they come to you. As soon as you yourself set eyes on your patient, you begin your general survey. And you're telling me, but like how? Easy. You start with looking at their mental state or sensorium. You want to look at their level of energy if they are an infant or a toddler. You want to see if they are in cardiopulmonary distress, or if they are ambulatory, if they're active, if they're bedridden, are they weak on one side, are they walking weird? You want to know if they're healthy. You look at their nutritional state. Are they too thin? Do they look too small? Are they too fat? Do they look too tall for their age? You want to look at their skin and their conjunctiva for their hydration state, and you want to make sure or tell yourself whether or not this patient is ill or well looking. Furthermore, before you go into systematic PE, you want to take the patient's vital signs. These are very specific in pediatrics. So for me, when I did a pediatric PE, I always began with temperature, pulse, and respiratory rate. Now, being that this is a theoretical case, they may ask you, how would you take these in an infant or young child? This is a trick question. In many adults and adolescents, usually we take the temperature, for example, orally. In an infant and young child, you take this as an axillary temperature. It is the safest and the easiest method, and also the most accurate with regard to children because it's close to the core. You could also say tympanic with, infrared, or like one of those ear tympanitic thermometers. Sorry, I'm blanking on the name, but ear thermometer. However, rectal thermometer is the most accurate, but you do not want to do this in a child that can sit up on their own, especially if it is made of glass or filled with mercury, the thermometer. So you want to say axillary if the patient is crying, or if the patient is basically throwing a tantrum. This is when you can help or ask the mother or a parent to help you hold the thermometer in the axillary area. With pulse and respiratory rate, with young children, you cannot take the pulse and respiratory rate by counting the chest fall and rise or palpation. That is incorrect. You take pulse and respiratory rates in infants and toddlers and basically pediatric patients by auscultation only, especially in infants. So do not tell them that you will count or palpate unless the patient is older, like school age or adolescence. Then you can palpate and use your technique where you palpate and then eye the respirations at the same time. In children, you auscultate for 1 full minute. Make sure you remember that. For infants and children, auscultation for pulse, auscultation for respiratory rate, 1 full minute for each. With blood pressure, this is not routinely taken in children less than 3 years of age unless the blood pressure is directly related to the chief complaint or clinical pathology or ongoing clinical process, pathological process. With anthropometric data, there are 3 major growth parameters in pediatrics. The first is weight. The second is length. If the person is less than 2 years old, you would use length. You would use height if the patient is greater than 2 years old. Head circumference is done if the patient is less than 3 years old. Other measurements like chest circumference, abdominal circumference, arm span, and UL ratio for children with growth disorders can also occur. And you also, again, want to note how to take these measurements. So, for example, with an infant, you cannot put them on a standing scale. So where would you weigh them? In a bassinet. You would place a older child, 2 or 3, on a weighing scale. How would you take their height or length, though? You would lie them down because of what? Good job, lumbar lordosis. So you want to make sure that you're getting the most accurate length and or height. After that, you also want to note where you are taking these measurements. So for example, if you lie the child down on the table using your tape measure, you want to go from the top of the head all the way to the bottom of the heel. So that is something that you want to remember. So for a height, however, if the patient is greater than 2 years old and they're able to stand, you can use a vertical board with an attached metric ruler and a horizontal headboard. So that's, helping them to keep that straight. However, if body positioning can be seen and you can do it, you can have them put their feet flat on the ground. You can have their back straight to the wall and measure them this way. With regard to head circumference, you want to use a non-distensible plastic tape measure, and you want to remember the anatomical landmarks that you will use for this measurement. So you go from the supraorbital ridge in front, and you extend circumferentially, so that's around, to include the most prominent part of the occipital portion of the skull. So this gives you the largest possible measurement of the head, and that's what you want to go over. The rest of the physical examination is conducted from head to toe, and do this again in the same order every time so that you're able to keep it as organized as possible. You want to remember IPA, EAP, and IPA. So I remember EAP as only GIT, so that's inspection, auscultation, and inspection, auscultation, and percussion. And then palpation, percussion for GIT. For IPA, it's inspection, percussion, and auscultation for cardiac. No, I'm joking. Inspection, percussion, and auscultation for cardiac, because you want to do the Heath-Lift thrills. And then IPPA, inspection, palpation, percussion, and auscultation, and all other systems. So basically, GIT, IAP, P, so EAP, and then cardiac is IPA. There's no percussion in the cardiac system. And then IPA for all other systems. Perform your physical examination with your initial impression in mind. So this means that, for example, if I am doing my head to toe, when I get to the system that I think is involved within my clinical impression, I'm going to do a more focused assessment in that area. So I want to be able to be sure that I get all of the physical examination findings I need to help me support my diagnosis. You also want to explore the major body systems that are possibly involved. So that speaks to the differentials. This is why I'm telling you it's very important that at the end of your HPI, you already have an idea of what your initial impression is, as well as your differential diagnoses, because you want to explore those further in the physical examination to get data that help support your findings. So for pediatrics, this whole system is unique to pediatrics. They don't do it anywhere else. You do not have to do this if you do not have a pediatric specialist or a pediatrician on your panel. So if you don't, just fast forward. I'll do the discussion after. But if you do, then stick around. So I'm just going to discuss this quickly so that you can work it into your discussion smoothly. So there are 5 diagnostic methods in pediatrics. You can look at the bold letters only. So basically you're looking for a symptom, sign, or laboratory finding that either has a pathognomonic finding for the disease that is found in the least number of diseases, that points to a specific organ or organ system, that points to a specific group of diseases, or that has a mechanism that is well understood. And what do we mean by this? So, first of all, pathognomonic for the disease would mean something that is basically, if you have that symptom, then there is no question that that is the disease that you are talking about. So, how would I say that? So, for example, if you have Gottron's rash, that is a pathognomonic cutaneous manifestation of juvenile dermatomyositis. So you could check, therefore, for other rashes in the body that are associated with this disease. If you use the findings that are found in the least number of diseases, you could use, that would be something like rhesus sardonicus, which is abnormal sustained spasms of the facial muscles that produce grinning, which is seen only in tetanus or poisoning with strychnine, which is a chemical. If you use the third rule, which is pointing to an organ or organ system, the best things like this are Murphy's sign, which is a great example and a maneuver done during your abdominal examination. It's useful in differentiating pain that is in the right upper quadrant. So Murphy's sign in this case definitely points to an abdominal system or abdominal organ dysfunction, and that's what you want to explore. Aside from Murphy's sign, you could also see other symptoms that relate to abdominal findings. So those would be things like nausea, vomiting, and then sometimes jaundice. So all of those could point to a clinically GIT-related pathology. If you're using the fourth rule, which is a group of diseases, this would be something like diarrhea. Diarrhea is a finding that could be the cause of, or could be caused by, multiple diseases. So you have to determine if it's acute or chronic. You have to determine the etiology. It could be infectious, it could be viral. You also have to note the nature and character of the stool. So those things point to a group of diseases that could either be infectious, that could be related to gastrointestinal pathology, they could be genetic, or they could be inflammatory like Crohn's disease. So these are things that you want to consider in the group of diseases category. Finally, a manifestation that is well understood mechanism. So a well understood mechanism would mean something like a disease process like anemia. It can develop due to the presence of specific findings like blood loss or hemorrhage, deficient red blood cell production, excessive red blood cell destruction, or both. So if you think about it that way, the mechanism of that specific disease process is very well understood. There is more than one mechanism that may be able to produce the symptom under the study. And this will mean that anemia, for example, is the most common or the most possible illness in this case. So it's usually classified, they have a lot of understanding of how it works. They know the etiologies that will be caused by it. They know the pathophysiology behind anemia. That's what they mean by a mechanism that is well understood. So, how do you use this? Or, better yet, what do you say if you don't know which one? My foolproof choice is always, always, always number 3. Using the symptom signs or laboratory findings that point to an organ or organ system. Because regardless of what your chief complaint is, regardless of your findings, you will always be able to figure out at least one organ system. So in my case, and in a case where I wouldn't know or I couldn't choose out of the 5, I would always choose organ or organ system to be on the safe side and explain my diagnosis that way. So this is more about discussion now. So when you are discussing your case, this applies to pretty much all of your cases, theoretical and otherwise. So if you state your initial impression. You state the method that you use to come to this conclusion. So like I said, I would say, my initial impression is this. I came to this conclusion using the system of finding symptoms, signs, and laboratory findings that point to a specific organ or organ system. This is because of the following. So I would say the organ system that my signs and symptoms pointed to, like for example, you would say the signs and symptoms, you would say the organ system that they pointed to was this, and then you would transition into the discussion of your differential diagnoses from there. When you get to your differential diagnoses, you explain at least 3 differentials. So that's 2 other diagnoses, including your most likely diagnosis, which is your initial impression. I always discuss them for flow in order of priority. I first put out the 2 less likely diagnoses, because if I discuss my most likely diagnosis last, it helps me bridge the discussion into why I established this as my final diagnosis. So you discuss the least likely diagnosis, you discuss the middle diagnosis, and then you discuss the most likely diagnosis at the end, because this helps you transition again into that establishment of your final diagnosis. For each differential, you want to discuss why you consider it, what made you consider it, so the data that you gathered from your HPI and your physical exam that helped you to consider it, and then why you ultimately ruled it out. So in this case, what is unexplainable about the differential that makes you rule this out? What about it makes you not want to believe that this is your diagnosis? In other words, basically, what's wrong with your differential? What is missing from your HPI or physical examination that does not support your differential being your final diagnosis? So that's kind of how you want to approach it. When you establish your diagnosis, you can again state the method you used and your rationale for using the diagnostic method. This is when you use your stock knowledge, your clinical knowledge, to expand upon your explanation and reasoning for your current diagnosis, as well as your initial impression. So you can connect your initial impression, your diagnosis, and your final diagnosis together. And then you explain at the end the other variables within your data that you collected that may not be covered by your initial impression. So for example, if you said that your initial impression was anemia because the patient came in complaining of fatigue, she's a teenager, and you elicited her menarche, her menstrual history, and she hadn't yet started to bleed. So you could explain that in the establishment of your diagnosis that you believe that this patient has anemia, iron deficiency anemia. So your initial impression would be anemia, but then in the establishment of your final diagnosis, you would then specify that you believe this to be iron deficiency anemia because of the following facts. So the other variables that I could not have explained at the time are, like, for example, if the panel asks me, well, what if she's bleeding? I would say then that I elicited the menstrual history from my patient. She has not yet started her menses. There has been no menarche as of now. I have ruled out the fact that this is menorrhagia, and that I can now consider other avenues for bleeding. However, I did note that in my history that she has had no changes to her bowel and bladder movements. She has noticed no bleeding per rectum or per orum or in any other orifices, and there is no family history of coagulative or anticoagulative disease or, coagulative disorders. So that would be something that I would say like that. Finally, for treatment and management, the first thing you want to do is say, the gold standard treatment for iron deficiency anemia in our example is iron supplementation. So then you want to think about, is this treatment available in the Philippines? So yes, we give iron in the Philippines. Is this treatment affordable? How much are iron pills in the Philippines? Is it feasible? Can the family afford it? Is there a better option? So you want to ask yourself that. Is there a better option? What can I tell my patients? What other things can I tell my patients about treatment and management? So for example, with iron pills, or if the patient doesn't like pills, the iron syrup, ew, it's so gross. You want to know, or you want to be able to tell your panel, yes, I will tell my patient to take Iron pills, she is a teenager, she says she is able to swallow them. I will also tell my patient to take the iron pill with orange juice because it could upset her stomach, and at least with the orange juice, it's more quickly absorbed. In addition, I can tell my patient to eat bananas because bananas contain a high volume of iron. So these are the things you would want to say in your treatment and management. You want to add if you would admit the patient, why or why not. So in this case, I would say, I would not admit this patient because of the fact that she is not suffering from any other signs and symptoms or life-threatening signs and symptoms of iron deficiency anemia. It can be managed as outpatient, so I would not admit her to the hospital, but I would, however, insist and make a follow-up appointment for her after X amount. So that's where the follow-up question comes in. And finally, prognosis. So this is one of the easiest parts. It basically asks you, is this condition curable? Can your patient live with this condition? Will it affect her day-to-day completely? Will there be a permanent disability? And how long will it take to see improvement? And after that, in pediatrics, you always want to touch upon the anticipatory guidelines. So depending upon the age group, the focus mostly is on the following 5 categories, and that is health, hygiene, nutrition, physical activity, and safety. So these are the things you want to talk about when you get to the end of your presentation. The FASI or the tribe or panel will ask you, what are the anticipatory guidelines for your patient in this case? So if my patient, going off that she's a teenager, for health, I would say the patient should do self-breast exams, or she should make sure that she is, self-breast exams, following up, and taking medication. That's something for health. For hygiene, I could say that a patient should ensure that she bathes regularly, brushes her teeth, takes care of her perineal area, starts to use deodorant, things like that. Teenager, right? So keeping in mind their age group at all times. For nutrition, it's important that my patient increases her intake of iron. It's also important that she gets all 5 food groups. That's something that we want to talk about as well. And because of her iron deficiency anemia, I can counsel her to eat more red meats if this is affordable for her family. With regard to physical activity, we always say decrease screen time. Make sure the patient is engaging in at least 30 minutes of physical activity 3 times a week so that they meet minimum criteria for exercise. And then finally, safety in the teenage age group. We want to make sure that this is a risk-taking age group, so we want to ensure their safety by allowing them to play and also explore, but however taking the appropriate precautions to prevent injury. So that would be like wearing helmets, wearing seatbelts in the car, things like that. That's kind of what they want you to say with anticipatory guidelines. So I hope that is clear. And finally, after all is said and done, you wrap up and conclude with 1 sentence, and then you pass with flying colors and get your Meritissimus. So thank you guys for listening to my presentation on pediatrics. Please feel free to ask me questions if you need to, and I hope this helps. So good luck and happy studying. Bye!